Hi, this is Jaron Crump with the Lupus Foundation of America, here with a new installment of the Expert Series, an educational podcast series featuring leading lupus experts with the focus of helping you live life well with lupus. The topic of today's installment is race-free eGFR calculations and implications for people living with lupus nephritis. As the title suggests, there was a recent revision to the Kidney Donor Profile Index, or KDPI, excluding race or identification of Black or African American potential donors. We're here to discuss what this means in relation to systemic lupus erythematosus and lupus nephritis patients. We have two experts on today's episode. First, we have Dr. Ashira Blazer, who is an assistant professor at the University of Maryland Division of Rheumatology and also co-directs the Lupus Center at the University of Maryland School of Medicine. Dr. Blazer is also a member of the Lupus Foundation of America's Medical Scientific Advisory Council. Dr. Blazer, thank you so much for joining us. Would you like to take a moment to introduce yourself to our listeners?
Yes, of course. And thank you so much for having me. Yeah, so now being a physician in Baltimore, you can imagine that I am treating lots of patients of color, and I am seeing lupus nephritis. And so as a longstanding researcher who's been interested in lupus nephritis and then the determinants of poor outcomes, including some genetic determinants, I'm very happy to be here discussing the importance of removing race from eGFR when thinking about kidney transplants.
Thank you so much for that, Dr. Blazer. Our other guest today is Dr. Denise Kimbrough, a nephrologist and fellow at the Ohio State University Wexner Medical Center, Division of Nephrology. Thank you so much for being here, Dr. Kimbrough. Would you like to introduce yourself?
Oh, yes, thank you so much. I am a current fellow in pediatric and adult nephrology, currently practicing at The Ohio State University as well as Nationwide Children's. I'm super excited to be here today to talk about how removing race, removing HCV, actual implications for our KDPIs are impacting or going to impact our minority communities and hopefully improve our chances at getting kidney transplants earlier and leading healthier lifestyles, even in the face of lupus nephritis.
Thank you so much, Dr. Kimbrough. And again, I'm very happy to have you both here. My first question today is for you, Dr. Blazer. If you could, discuss lupus nephritis prevalence rates and highlight populations disproportionately impacted by SLE and lupus nephritis and the overall burden of disease rates of kidney failure in disparate populations.
Yeah, so lupus is thought to be one of those uncommon common disorders, right? And so we're finding that even though the incidence and prevalence is going up, it's still a relatively uncommon disease. But we know that Black and brown populations are more likely to have lupus. And then given that they develop lupus, they're more likely to have internal organ involvement, especially kidney disease. So, for example, we can expect around 20 to 60% of people with lupus to develop nephritis at some point during the course of their illness. But for African Americans, Hispanic Americans, and also Asian Americans who develop lupus, that number is closer to the 50 or 60% mark. Whereas for white Americans, it's closer to that 30% mark. And so there's disparities in who develops lupus nephritis, but then there are also disparities in who develops end-stage kidney disease, given that they get lupus nephritis. So some estimates even say that about half of the people living with end-stage kidney disease with lupus nephritis are African American. And so this is a population that is at very high risk. And it's also a population that's in high need of getting kidney transplants should they develop end-stage kidney disease.
Thank you so much, Dr. Blazer. Dr. Kimbrough, my next question is for you. Can you explain the difference between lupus nephritis and other kidney diseases, and also what circumstances tend to cause Black lupus nephritis patients to be of special concern when it comes to kidney health?
Sure. So when we think about lupus nephritis and we think about generic kidney disease, one of the main differences or components is how these diseases take place. So lupus nephritis is a kidney disease that is related to an autoimmune disease. So you have an immunological impact causing damage to your kidney. Whereas when we have like CKD or we have polycystic kidney disease, these diseases can develop as a result of other conditions or other pathologies that a patient may have. You may have hypertension, and that affects your kidney. And so later on in life, you have a little bit of chronic kidney disease, or you have a genetic mutation, like in the instance of polycystic kidney disease. And so you're born with this predisposition to make these cysts and ultimately lead to declining renal function. One of the things that we look for when we're looking why lupus nephritis disproportionately, especially affects our Black and Brown communities, is in the stages and in the processes of getting diagnosed with lupus nephritis. Often it's a very long journey for our patients, depending on where they are, because especially those that start having symptoms as pediatric patients or young adults or young adolescents, and getting in contact with someone who's aware of the disease process for lupus, pointing it out, figuring it out, and getting them on the right therapies early enough to minimize their chances of developing the kidney disease. That process alone often leads to a 60% increase in our Black and Brown communities because they don't know what to look for. Their symptoms are overlooked, their diagnosis takes longer, and then explaining the therapies and ensuring they have access to those therapies as well also takes longer, leading to the quicker development of lupus nephritis.
Thank you, Dr. Kimbrough. I'd like to ask a follow-up question. You shared a bit already, but could you discuss current challenges with access to transplantation in Black and Brown communities who experience kidney failure?
Oh, of course. So this is very multifactorial, right? The more and more we learn about just where our Black and Brown population find themselves in, we know that there are multiple factors that are affecting just the ability to understand what a transplant is. We have both social determinants of health. So this is just healthcare in general, access to adequate healthcare, access to adequate specialists. Where you have a transplant nephrologist or a transplant facility close enough where you can be evaluated. There are the systemic inequities. So oftentimes in our Caucasian counterparts, living donor kidney transplant is pushed. But for most of our African American or Brown population, it's often relying on deceased donor transplantation. And when you rely on deceased donor transplantation, you're left at the mercy of the system to have that ability. We aren't educated as well within our Black and Brown populations on what being a living donor means. What are the consequences? What are the expected outlooks? And a lot of our populations are also challenged with other health conditions that may eliminate their ability to be donors to their families as well, based on current systems. There's cultural biases in understanding what you need, like understanding our degree of losing an organ or taking a part of out of you that you came in this world with, that oftentimes if we're not able to have those intimate conversations and understand culturally with our patients what their thought process is around their religion or their body in general, or take the time to do that, it can limit their family's ability to be living donors. And then there are, of course, the financial barriers, meaning that even though most people, when they go into having end-stage renal disease, they go on Medicare, they go on Medicaid, and they have all of their healthcare taken care of. Once you get that transplant, you then also have to be able to afford your medication. Transplant medications are expensive. The immunosuppressives are expensive. The constant visits to the doctor are expensive. And you often lose that Medicare, Medicaid a year after. So even though we get successfully transplanted, we also have the highest rate of losing our transplants quicker compared to our counterparts, because those things aren't discussed upfront to ensure that our patients have the adequate financial needs to be able to take care of their transplant if they get it.
Thank you so much for that. Dr. Blazer, is there anything that you'd like to add just in terms of the lack of donations from Black and Brown donors and how this could limit opportunities for transplantation?
Yes, for sure. We all know that Black and Brown patients face disparities. And I think that this is related to access to care, access to quality long-term care, education, all the things that we just spoke about. But also there are differences in physician choice. And that may be due to biases on the part of physicians, but it also may be due to biases that are baked into the ways that we assess kidneys, right? And so this is the topic of the moment, right? So we all know that Black and Brown patients are less likely to have longevity with the kidneys that are transplanted. And when we think upfront about social issues that might occur, we may unknowingly place higher emphasis on social factors when thinking about who to get a transplant to. And that means that physicians may make choices that limit transplant options. And then, of course, when we have race-based calculations, which we'll talk about just shortly, the concept that kidneys from African American donors are inherently higher risk without thinking about the reasons why that might be, then further limits what patients have access to. So we can end up punishing patients twice for being in a population that is historically marginalized. And I think when those two things come together, the systemic factors that influence transplantation, and then also our biases and the biases that are baked into our assessment tools, we end up having a population that's at extremely high need, but is also less likely to get that help.
Thank you so much for bringing that up. Since you mentioned the tools that are used when making these determinations, could you speak to the broader implications of removing race from medical algorithms in lupus research and treatment, particularly in relation to health equity?
For sure. Yeah. So I think for way too long, as a community, as a medical community, we have labored under this delusion that the differences in outcomes across race are somehow due to differences in biology or genetics. And I think when we create tools of assessment that include a race calculation, embedded in that is that if you're part of this racial group, you will certainly have this poorer outcome, or your organs are higher risk, specifically due to, in this case, Blackness, right? That is actually a very old thought. It is also a very racially problematic thought. And we are thankfully getting to the point where we're disentangling what we mean by race, right? Is there truly a risk factor? Does that apply to everyone who's a part of a racial group, or may this apply to a subset of people who are part of a racial group? Are there other reasons, biologic, social, otherwise, why a kidney might be higher risk or not? And so I think as we start to remove race, we start to become more intentional about what it is that we're discussing, and then how we can make a true assessment, both to understand the range of risk of all kidneys, and then also to understand how we might be able to mitigate that risk, or how we might be able to better match donor kidneys to recipients.
Thank you so much. It's really interesting. Dr. Kimbrough, what impact do you expect the removal of race from the KDPI to have on transplant equity and outcomes for Black patients with lupus nephritis?
I think to answer this question, we first have to understand what the KDPI index is and what it has stood for so long. So for us, it's a numerical score, right? Where people are undergoing their kidney transplant evaluation, or really the donor, we're undergoing evaluation. And we're trying to determine what is the quality of the kidney and what will be the expected longevity of a kidney that we are about to transplant from a deceased donor. And this doesn't always include our living donors. So specifically, these are surgeons who get a document to read about the person that is now donating their kidney. It comes from our life organizations. It has their full medical health record, what they've experienced, what they've exposed. And then they get certain scores or certain factors based on, do they have chronic conditions? For the longest as well, this included, were they Black or were they a minority? That also gave you a negative factor. Or did they have a certain type of viral illness? Did they have HCV? Did they have hepatitis B? Those type of conditions. Any of those factors, including just having Black race, would have automatically gave you a KDPI index that was higher than 50%. A kidney that's higher than 50% means that it's not going to function long. And so that limits who the surgeons would choose to give it to, even if they had to offer it. It might be a lupus patient who has been sitting on the transplant list for 6 years. But if that kidney had an 85% KDPI and they thought they would need the kidney for 10 years, they chose not to give it to them. Regardless of whether it was a blood match, a perfect HLA match, it didn't matter. So you can imagine removing just race in these infective predictors will automatically open up more kidneys for this population in general. Also, it removes the bias that the surgeons have on what they think is an appropriate kidney to be able to implant in someone, just based on how long they may or may not have it or give them time. And whether they're, especially with lupus, where there's not always the chance that your disease process may reoccur. And if you're doing well and you're having good health care, you can definitely take care of a kidney regardless of where it is. This hasn't been as much of a factor for our younger population, which is also goes back to the point of we're limited in these populations of when they're getting diagnosed with their lupus disease, because the earlier on they get under therapies and the earlier on we find out they have any form of lupus nephritis, if they're under the age of 18, they automatically get kidneys that had a low KDPI. So they had a good longevity kidney, and that factor was also removed. But often this doesn't happen for a lot of our patients. They're well above the age of 18 when their disease process gets to this point.
And I think Dr. Kimbrough made a really important point there, right? So this is a system by which a surgeon gets to assess a kidney donor and decide whether or not that kidney is one that they would like to transplant, right? All of these phases involve physician choice. And I think that, because surgeons who have higher success rates, transplant kidneys that last longer, tend to do better in their careers. In fact, those are metrics that they are beholden to as surgeons, right? When they're confronted with this kidney that has this high score, they're going to weed that out at a higher rate, both because they want better outcomes for their patients, but also because they want better outcomes for themselves in their careers, right? And so this creates a very high incentive to really weed out kidneys that would otherwise be beneficial for patients, and particularly for patients of color who need to receive these kidneys.
Thank you both so much for such insightful answers to that question. I'm going to pose another question. I know, Dr. Blazer, you shared some information with us via email prior to this, and because Dr. Kimbrough mentioned HCV specifically, could you explain why hepatitis C was originally a factor in evaluating kidney donors and what advances led to its removal from the criteria?
So hepatitis C was considered a chronic incurable viral illness. And so when donors were found to have hepatitis C, the thought was that this was something that would impact the organ, the kidney, and that this kidney would fail more quickly. So more recently, we have the availability of direct-acting antivirals, which are able to all but remove hepatitis C from that organ. And so when you transplant the kidney, it's likely to live as long as a kidney that didn't come from a hepatitis C donor. And so in the past, we would need to think of that kidney as higher risk. But with the advancements in the medical treatment of hepatitis C, we now are able to salvage those kidneys and have them last a comparable time to kidney donors who don't have hepatitis C. And so this leads to an increase in the availability of kidneys, and it also may decrease wait times for people who need to receive them.
Dr. Kimbrough, would you like to add anything?
Thank you for that. The only thing I would add is that the other limiting factor that we found more so when we weren't accepting the HCV kidneys was because of education. Again, another social determinant of health that people seem to believe, if, especially for minorities, women, and those who had significantly less education, meaning nothing over a middle school rated education, would not be able to take those medications and stick to the regimen that would be necessary to ensure that the virus did not replicate and then cause other issues in them. So having HCV in the equation originally would automatically put those individuals at a least likely status to actually get those kidneys. And oftentimes those kidneys would be the best blood matches for these patients and HLA matches. But if they didn't believe they could stick to that regimen, they wouldn't offer it.
Actually, that just makes me have a question because, again, I'm a rheumatologist. I treat lupus patients, and I'm not so much on the side of thinking about who gets a transplant or not. So that's actually fascinating. So if a treating physician believes that a patient would not be able to adhere to a treatment regimen, they may then pass on giving them this kind of kidney. Is this what we're saying?
Yes, ma'am. Part of the adult transplant evaluation is they fill out essentially for lack of better, a standardized test to see what their education level is rated at.
Oh, wow. Wow.
And that's and it gives them a grade based on what kind of education they will need to go through in order to prepare just for a renal transplant.
Yeah. So then you would think that because there are ways to improve treatment adherence, right? Maybe having someone provide the medication, reminders, ancillary services, right? So instead of then enrolling that patient in an education program or getting social work or some sort of mechanism for supporting the patient, you would just pass on the kidney.
Yep,
Or,
that patient would then be listed as eligible on the wait list, but not for an HCV positive kidney.
oh, wow. Wow.
Mhm.
And all these things are quite subjective, right?
Yes,
And
oh, of
instead of,
course.
yeah, and instead of supporting patients, it's just let's put them in a position to wait longer for a life-saving intervention.
Mhm. And this is one that both impacts our adult population and pediatric population. I have actually had a pediatric patient, the same type of thing, where because they are not willing to accept an HCV kidney for him, he doesn't have the family support or or the social support system where they think he would be able to stick to the regimen. He's going to transition soon to the adult world where his chances will be harder to get a kidney. And he has not been transplanted in over 10 years.
That's really sad. That's very
Mhm,
sad. Some of the literature I know about this is from cardiology, but
mhm.
there's a series of papers by Dr. Khadija Bathet that came out around heart transplantation and racial biases in choices around heart transplantation. And, it was over 400 physicians who were given multiple vignettes about whether or not they would transfer this patient or give them an LVAD, which is sort of an assist device that allows a person to wait longer for a heart transplant. And all the vignettes were exactly the same, but the picture was different. So the pictures varied by race or gender. And of course, the white male patient was most likely to be listed for the heart transplant in this theoretical case. But when you asked why it was that the physicians were saying that the other patients should wait longer, it was based on race and gender. The physicians thought that there may not be as much support, that there may not be as much availability of social support, or they may not adhere to their treatment regimen, right? So there are all these thoughts about what Black or brown or female patients might do or how they might behave when given this limited resource. And so, it really becomes a problem when we have to make these cognitive leaps and we use race as shortcut for that.
Exactly. Race and race, or even just gender in
Mhm.
general as well, becomes a factor. And I don't 100% know how to remove that bias
Right.
right
Right.
now because of how the system is set up and
Mhm.
ultimately who's making these decisions, right? Unless we put more people who are advocates and who, as well as we educate in order to try to help this process reduce the bias that is inherent to be in it regardless, based on how it's established.
Sure, sure. And of course, for our lupus population, mostly women of color, right? So this is
Correct.
something that is particularly important for lupus patients.
Thank you both so much for that. Are lupus nephritis patients at greater risk if they accept a kidney from someone who had hepatitis C, or would you expect a similar outcome as you would for someone who did not have lupus nephritis but had kidney disease?
So there has actually been research that has shown that there is no difference in the outcomes, whether or not you get an HCV kidney or not. Because that was also a factor before that was highly thought that there would be differences in how long the kidney lasts or what quality it was or how well it performed and whether or not they developed CKD further. But there have been multiple studies that have proven that that is not.
Thank you so much. How might changes to KDPI scoring affect lupus patients who are on the kidney transplant waitlist, especially in terms of improving access to viable organs? And I think you actually might have explained a bit of that already with the previous question.
Yes, for sure. And essentially, what it will do is make more organs available to choose from, right? So if we have more to choose from, and we're also lowering that KDPI for these organs now, because instead of being rated because they were from a Black or brown person with hypertension and diabetes, removing just that factor of race, and 2 studies has been shown to reduce that KDPI closer to the same 15% cutoff point as Caucasian kidneys alone that did before just didn't have that factor in. So that opens up a world of possibilities and just the ability to choose from multiple organs for our patients with lupus nephritis in general.
Right. So I think it's about broadening the availability of kidneys, right? And I think one thing that we discussed before was that the KDPI score is used in particular for deceased donors. And because there are fewer living donors that hail from these underserved racial groups, this score is particularly impactful on the kidneys that Black and brown patients might receive. And so this, I think, is very important for lupus patients because of the demographics that are most heavily affected by lupus, because it's going to open up exactly the pool of kidneys that is most likely to go to our patient population.
Thank you so much. And my final question, again, for both of you, we can start with Dr. Blazer, but you already mentioned a bit of this. Lupus disproportionately affects women of color. How do you see this policy improving outcomes for this population in terms of kidney health and transplantation?
Yeah, so I think that this is going to increase the number of kidneys that are considered at low risk for transplantation, and therefore can decrease the wait times for women of color who are waiting for kidneys. So kidneys that are coming from groups that are more congruent with each other are less likely to be mismatched, so immunologically mismatched. And so I think that we're going to be able to see more quality kidneys that are well matched to the recipients being available and having more kidneys to choose from earlier. And we know that patients who get earlier kidney transplants are more likely to live longer than patients who don't. And so I think that this decision will be really impactful. I think the other thing is it will allow us to think more deeply about the reasons why one kidney or another might be high risk or not, rather than just lumping everything with race. So, for example, I've been studying apolipoprotein L1 or ApoL1 polymorphisms. So there are these genetic mutations that are present in homozygous form in about 13% of African Americans. And that genetic risk factor does increase the likelihood that someone goes on to end-stage kidney disease. But on the transplant side, kidneys that come from donors who are APOL1 high risk are more likely to fail, right? Now, that's not kidneys that come from patients who are not APOL1 high risk. And so when we take away race and we start to think, are there factors that are present or not that may decrease the longevity of this graft, we can start to think in more granular detail. Is this person, an APOL1 high risk genotype carrier? Is this donor a high risk genotype carrier or not, right? And so we can start to parse out the kidneys that are likely to survive versus not.
Thank you so much, Dr. Blazer. I'm glad that we were able to have this conversation. Thank you so much to our listeners for tuning into this episode of the Expert Series, where we discussed race-free eGFR calculations and implications for people living with lupus nephritis. Our experts on this episode were Dr. Ashira Blazer and Dr. Denise Kimbrough. I'm Jaron Crome with the Lupus Foundation of America. Thanks again.